So in abdominal aortic aneurysm, AAAs, A smaller than 0. For 4 is a 5-year risk for rupture is 2%. Surveillance 24 to 36 months. AAAs 4 to 5 centimeters. The 5-year risk rupture is 3 to 12%. So surveillance every 6 to 12 months. And then 5 to 6 centimeters, 5-year risk of rupture is 25%. And surgery can be considered at 5.5 centimeters or greater. Abdominal aortic aneurysm, tenderness or pain, rapid expansion greater than 0.5 centimeters a year. Continue discussion on abdominal aortic aneurysm. So active smoking is the highest rate of aneurysm expansion or rupture. So what would be your board review question is saying is, what would be the first thing if the patient is actively smoking and does not require an emergent repair is smoking cessation. So remember, this involves the connective tissue degeneration in the aortic wall. So it can either do open surgical repair or endovascular aneurysm repair. Postoperative risk, depending on the postoperative risk, the location of the aneurysm, involvement of the renal and mesenteric arteries, and surgical repair may require aortic cross clamping, which can give complications of renal failure. Endovascular repair in a patient who are not candidates for surgery. So the problem with the endovascular repair is you can have endograft leak, continued blood flow into their aneurysm sac. Screening. This is important. Screening is important. I like to ask questions on boards if you have to follow up and work on these patients in the outpatient setting, or even designating screening in an inpatient setting for where they need to follow up with. Men, ages 65 to 75 with smoking history. If they smoked at least 100 cigarettes in lifetime to qualify. So it's 100 cigarettes, 5 packs. If they smoke more than 5 packs, they qualify. Need to get a one-time abdominal duplex ultrasound. All right, now let's go to a board question right here. Now let's do this one correctly. What is the following is a minimum number of diagnostic criteria to establish the diagnosis of acute pericarditis in a patient. So we're going to pericarditis. So we know that right away. So let's read this. 32-year-old male presents with acute onset of sharp pleuritic chest pain that worsens when he's laying supine, improves when he sits forward. So worse when he's laying back and leaning forward. He has a low-grade fever and no significant past medical history. On examination, he has a high-pitched triphasic pericardial friction rub is heard. His EEG shows diffuse ST elevation and ST segment and PR segment depression. Echo reveals a small pericardial effusion. What is the following is the minimum number of diagnostic criteria? This is not a fair question, is it? But this is going to help you learn on this. Required to establish diagnosis of acute pericarditis in this patient. All right, the diagnosis of acute pericarditis is established when you at least have 2 of the 4 criteria. So let's go through the 4 criteria. So 2 of the 4, and we have pericarditis. Typical pericardial chest pain. So what is that? Sharp and pleuritic, often worsening with inspiration, breathing in, coughing, improves with leaning forward. The patient sits up and leans forward. The pain is usually retrosternal or precordial, behind the sternum or in front of the heart, but it can radiate to the trapezius ridge due to the phrenic nerve involvement. So that's 1. Typical pericardial chest pain. You can have a pericardial friction rub when we put that stethoscope on the heart. New widespread ST segment elevation or PR segment depression on EKG, and new or worsening pericardial infusion. Let's go through this one. This is a clinical scenario. So we did the multiple choice. Now this is the patient presenting. 36-year-old male with no past medical history, has fever, chills, worsening shortness of breath when laying down, sharp stabbing chest pain. This is a clinical scenario. So take a look at this. Look at this EKG, and we're going to draw on here, okay? See this right here? We're drawing on here. We're having with acute pericarditis, and we have ST segment elevation, and we have PR segment depression in lead 2. Let's take a look at lead 2. PR segment depression in lead 2. Lead 2 is going to have PR segment depression. ST elevation and PR segment depression. ST elevation. Pericardial disease. Acute pericarditis requires at least 2 of the following symptoms or signs. Sharp pain, we talked about these. This should be easy to you, and you should remember this because we're hitting this multiple ways. Sharp polaric chest pain that radiates to the trapezius ridge and relieved by sitting forward. Positive pericardial friction rub. ST elevation, all leads except AVR and V1. PR segment depression. T wave inversion occurs after a few waves. Pericardial effusion on echo, present in 2/3 of patients. If diagnosis uncertain, obtain CT, cardiac CT or MRI, and it will show pericardial thickening or enhanced pericardial gadolinium uptake. Causes idiopathic is us idiots do not know why. It's presumed to be viral. This is 80-90%. White blood count greater than 13,000 suggests bacterial pericarditis. Can also occur acute MI and aortic dissection, trauma, chest radiation, receiving radiation, neoplasms, uremia can cause this, cardiac surgery, autoimmune disease such as SLE. Medications such as dantrolene can cause this, hydralazine, INH, phenytoin, and procainamide can cause pericardial disease. Acute pericarditis continued. Poor prognostic factors, temperature greater than 38, cardiac tamponade, trauma, anticoagulation therapy, immunosuppressed state. Myocarditis, myopericarditis, we have elevation in cardiac troponin IRT. Myopericarditis is concurrent inflammation of both the myocardium and pericardium, in which the predominant pericardium involvement and evidence of myocardial injury. So you have pericardial and myocardium. So you have myocardial injury with an elevated troponin without significant ventricular dysfunction. It is considered part of the spectrum with pericarditis and myocarditis. So poor prognosis factors continue would be a large pericardial effusion, echo free space greater than 20 millimeters. Recurrent pericarditis is having recurrent pericarditis is defined as new episodes of pericardium inflammation occurring after symptomatic free interval at least 3 to 6 weeks after a previous episode, with the diagnosis requiring at least 2 of the following. Here it goes. The chest pain, pericardial rub, EKG changes, new or worsening pericardial effusion or elevated inflammatory markers. It affects about 15 to 30% of patients after the first episode of acute pericarditis, with the most recurrence occurring within 3 to 6 months. Recurrence beyond 12 months is uncommon. All right, let's talk about treatment of acute pericarditis. Treatment: aspirin or other NSAIDs, ibuprofen or indomethacin, plus colchicine. Addition of colchicine causes more rapid improvement and reduces the recurrence rate. Now, aspirin is preferred in patients with concomitant where they have ischemic heart disease and pericarditis. But you also have to watch NSAIDs because NSAIDs have what? They have the problem of cardiovascular side effects, including increased risk of vascular events such as myocardial infarction and stroke. Remember, NSAIDs can cause this, heart failure and hypotension. You also can have renal adverse events, including acute kidney injury, sodium and fluid retention. Aspirin plus colchicine for pericarditis in early post-myocardial infarction period, adding steroids if no response to above therapy as initial therapy if pericarditis is caused by connective tissue disorder. We really want to avoid steroids, and we'll explain. Use moderate doses for several weeks, then gradually begin tapering. Duration of therapy, 1 to 2 weeks for NSAIDs, colchicine for 3 months. If there's recurrent pericarditis, restart NSAIDs, colchicine, for use for 6 months. Poor response to NSAIDs, use steroids with recurrence rate of 15 to 30%. Colchicine offers the best prophylaxis for recurrent pericarditis, and steroids increase the risk. So that's why we try to avoid steroids. They increase the risk of recurrence in refractory cases. Remember, colchicine can be added. What's colchicine side effects? Famous one: diarrhea, nausea, and cramping, vomiting. Can have hypotension, bradycardia. Corticosteroids only used in refractory cases in which NSAIDs, ASA, and colchicine have failed, or recurrent or autoimmune pericarditis. Where for patients with multiple reoccurrence, or refractory disease, immunosuppressive agents should be used. Azathioprine, IVIG, can be used especially in those with inflammatory phenotype. They have fever and elevated C-reactive protein. When you use prednisone, it's going to be usually 60 milligrams per day with tapering 5 milligrams every 3 days until 20 milligrams a day is reached. Pericardiectomy is last resort for severe refractory cases, and the aspirin dose is going to be 650 milligrams. Just think of these dosings are so huge. Just think about the GI distress that somebody's going to have. You probably need to consider adding a PPI. Aspirin is going to be 650 milligrams, Q4 to 6 hours, and ibuprofen 400 to 800 milligrams, Q6 to 8 hours for 3 to 4 weeks duration. Just think about the gastric distress that's going to happen in that. All right, now let's go over here and let's do some questions. Now, remember, we're going to go and we're going to read the answer first. Which of the following is most reliable, distinguishes constrictive pericarditis from restrictive cardiomyopathy? So, what is restrictive cardiomyopathy? So, constrictive pericarditis, just think about the pericardium is holding the heart and is holding the heart hostage. Restrictive cardiomyopathy is abnormal ventricle compliance without predominant ventricle dilation, hypertrophy, or systolic dysfunction. This needs to be emphasized to distinguish it from constrictive pericarditis, in which the pericardial rather than a myocardial process. Constrictive pericarditis is a condition in which the pericardium, that's the sac surrounding the heart, becomes thickened and rigid, restricting the heart's ability to expand around and fill with blood. So let's take a look right now at our question. This is a 58-year-old man who presents with progressive low extremity edema, abdominal distension, and exertion dyspnea. He has a history of prior cardiac surgery 10 years ago. He had a cardiac surgery 10 years ago, and on examination, he has elevated jugular venous pressure. He has a pericardial knock and hepatomegaly. Echocardiogram reveals a thickened pericardium, septal bounce, and marked respiratory variation in mitral inflow velocities. Cardiac catheterization demonstrates equal diastolic pressure in all 4 chambers and the discordant changes in the left and right vascular systolic pressures with respiration. Okay, so what is our question? We'll go back to our question again. Is what distinguishes constrictive pericarditis from restrictive pericarditis? So choice A, left atrial involvement. Now remember, what's most reliably, this is kind of a trick question, not a fair question. Pericardial calcification on chest imaging. So constrictive pericarditis from restrictive, okay? Can there be pericardial calcification on chest imaging? Yes, there can be. Respiration variation in septal position. There's a septal bounce and enhanced ventricle interdependence. Enhanced ventricle interdependence. Okay, elevated BNP. So what's BNP? Brain natriuretic peptide. It's a 32 amino acid peptide hormone primarily synthesized and secreted by the ventricle cardiomyocytes in response to increased wall stress, such as volume or pressure overload. When you see this, you can see this in acute coronary syndromes, left ventricle hypertrophy, valvular heart disease, pericardial disease, atrial fibrillation, myocarditis. Also going to be seen in advanced age and anemia, obstructive sleep apnea, severe pneumonia, pulmonary embolism, pulmonary artery hypertension. critical illness. So elevated BNP and restrictive cardiomyopathy reflects increased ventricle filling pressures and is useful for diagnosis and prognosis. All right, so out of these, what is going to be our best? So most reliable is going to be answer C. Answer C is respiratory variation in ventricle septal position, that's a septal bounce, and enhanced ventricle independence. So remember, in this question, is it a fair question? Probably not, but this is what you'll see on boards, is most reliable distinguishing constrictive pericarditis. Most reliable is respiratory variation in this ventricle septal position, septal bounce, and enhanced ventricular independence. Explanation: constrictive pericarditis is characterized by a dissociation of the interthoracic and intercardiac pressures and enhanced ventricular interdependence, which manifests in respiratory variation in ventricle septal position. That's that septal bounce and discordant changes in ventricle pressures on respiration. Septal bounce refers to an abnormal, rapid, and paradoxical motion of the intraventricular septum, typically seen during early diastolic, and then where septum abruptly moves from the left ventricle and then recoils. Enhanced ventricular independence. This is when the interventricular septum shifts leftward towards inspiration, impeding the left ventricle filling. We talked about this before, causing a drop in stroke volume and cardiac and pulse pressure. This is manifested as what? Pulsus paradoxus, things we talked about. So important things to remember. All right, now it's a clinical presentation. 67-year-old male with past medical history of hypertension, diabetes mellitus, and coronary artery disease noted for dyspnea, fatigue, edema, and elevated JVD, and hepatomegaly. Echo is low voltage. Symptoms have been worsening for several months. So that's a clinical scenario. Now let's look at the EKG. See, look at how low voltage this is. Very low voltage electrocardiogram, ECG, refers to reduction in amplitude. See, look at the QRS. Look how small the QRS complexes are. It's defined as QRS amplitude less than 0.5 milliseconds in limb leads and less than 0.1 milliseconds in pericardial leads. All right, so when we looked at this, this is in constrictive pericarditis. See this right here? See this kind of shield? It's present in approximately 50% of the cases, pericardial calcification on chest x-rays. Now, you say is, well, why wasn't that the answer? Well, what is the most likely? Most likely. All right, let's talk about constrictive pericarditis. It's a thickened pericardium, normal ventricle contraction, impaired ventricle filling. The CT or MRI is going to show thickened pericardium. Cardiac cath shows equalization of diastolic pressures in all chambers. Now, the treatment is going to be, you can use loop diuretics to reduce dyspnea and edema, but avoid overdiuresis due to higher filling pressures to maintain cardiac output. So 2 to 3 months of an anti-inflammatory medication before you do a surgical pericardiectomy. Pericardiectomy is the only effective treatment in chronic constrictive pericarditis. This is indicated in patients with New York Heart Association Class 2 and Class 3 heart failure symptoms. You need to avoid, you can use loop diuretics, but you need to avoid overdiuresis, as we discussed. So cardiac catheterization of equal diastolic pressures in all chambers in constrictive pericarditis. Where is this also seen? Cardiac tamponade. You can have similar findings in restrictive cardiomyopathy and severe tricuspid regurgitation. The EKG shows low voltage, as we saw in our example, may show pericardial calcification. Echo shows thickened pericardium, normal ventricle contraction, impaired ventricular filling. CT or MRI shows thickened pericardium. Cardiac cath shows equalization of diastolic pressures in all chambers. Constrictive pericarditis is impaired filling due to restraint of ventricular diastolic expansion, because this is held in. Remember, the heart has like a little sentence, heart coffin right there, and it's holding it tight in its heart coffin. Resistant of restraint of ventricular diastolic expansion by stiff pericardium, causing dyspnea, fatigue, and peripheral edema. Clinical feature, rigid pericardium leads to impaired cardiac filling. You have gradual onset of dyspnea, pedal edema, ascites, hepatomegaly, increased JVD with sharp Y descent, positive Kussmaul sign, elevated JVT on inspiration, sharp early diastolic sound, and pericardial knock. The heart can't fill, and you get an extra pericardial knock. The heart can't fill, so you get this extra pericardial knock. Causes can be TB, viral, prior cardiac surgery, collagen vascular disease, uremia, radiation can cause this malignancy. Pericarditis, common manifestations of lupus. 40% of patients with lupus. I'll go back to it real quick. It can also be neutropenic, a neutrophilic pericardial effusion, tissue that gets infected. This can be purulent pericarditis. Infection can be bacterial, fungal, or parasitic. Can lead to tamponade or septic shock. Constrictive pericarditis. Physical findings, pericardial knock, pulsus paradoxus. I think we beat this pulsus paradoxus to death. Basically, remember, we're going to do this again, is that the right side pushes in the left side, the heart is in this heart coffin, and it can't squeeze out. You can have pleural effusion, congestive hepatomegaly, peripheral edema or ascites. Pericardium is rigid and non-compliant. The stiffer the pericardium, the worse the symptoms. Pericardial thickening, impaired diastolic filling, decreased total cardiac volume. And you have right-sided heart failure symptoms, which is going to be peripheral edema, ascites, and fatigue. The BNP is going to be low and or normal. Remember in our multiple choice question, it all fits together. All fits together. So using these multiple choice questions and putting this stuff in your brain. Echo is going to show dilation of the IVC in ventricular septal shift during respiration.